Myelodysplastic syndromes. So myelodysplastic syndromes are a group of cancers in which immature blood cells in the bone marrow do not mature or become healthy blood cells. So the slide here just kind of has some basic information about myelodysplastic syndrome. The features are pretty relevant to all myelodysplastic syndromes, as well as the management that's listed there, but we will go through each of these individually. So myelodysplastic syndromes, some factors or etiology that can lead to a myelodysplastic syndrome is age. This is most common in older adults. Therapy-related causes, so patients who have had previous chemotherapy or radiation therapy. This can also lead to therapy-related MDS or myelodysplastic syndrome. De novo mutations, so they occur without prior therapy and actually account for the majority of these myelodysplastic syndrome cases. Some common morphological findings. So on the lab side, we will see a progressive cytopenia, so they'll have a decrease in peripheral blood cell counts, despite having a cellular bone marrow, basically a normal bone marrow. They'll have dyspoesis, so they'll have abnormal maturation in one or more hematopoietic cell lines, so either in the erythroid, myeloid, or megakaryocytic line. They'll have disruption of apoptosis, so they'll have increased apoptosis in early disease, and then they'll go to decreased apoptosis near leukemic transformation, and this allows the neoplastic cell survival and expansion. For the therapy-related myelodysplastic syndrome, this time to onset can be anywhere from 4 to 7 years, usually after exposure to the chemotherapy or radiation. For classification, the WHO places the therapy-related myelodysplastic syndrome under therapy-related myeloid neoplasm, and it is actually grouped within the acute myeloid leukemia category. For morphologic features in the peripheral blood and bone marrow, you'll have poetic features seen in major myeloid cell lines. So these abnormalities are visible in both peripheral blood and bone marrow, which can affect the three major hematopoietic lineages, such as dis erythropoiesis, dis myelopoiesis, and dis megakaryopoiesis. So dyserythropoiesis refers to abnormal red blood cell morphology, which can be observed in the peripheral blood smear. So some features in the blood smear is we would see oval macrocytes, which is actually the most common finding. And this is actually an important clue. So if your vitamin B12 and folate levels are normal, we would then consider a myelodysplastic syndrome. We might see hypochromic microcytes, which are pale, small red blood cells with reduced hemoglobin. If the iron levels are normal, myelodysplastic syndrome is likely a cause. If we have dimorphic red blood cell populations may also be present. So the presence of two distinct red blood cell populations, so normocytic and microcytic or something like that would be a consideration for this. Poikilocytosis, which is the variation in red blood cells. We'll also see basophilic stippling, which is the fine or coarse blue granules in red blood cell cytoplasm, which indicates abnormal ribosomal aggregation. We may also see Howell-Jolly bodies, which are actually nuclear remnants that are left over in the red blood cells, but these are usually removed by the spleen, but they could reflect dysplastic erythropoiesis. We may also see siderocytes. So these are red blood cells that contain iron granules, and this can be seen with a special stain called the Prussian blue stain. For bone marrow findings, so in the bone marrow, dyserythropoiesis is characterized by abnormal development and nuclear maturation of erythroid precursors. So some features that we would see in the bone marrow for dyserythropoiesis is we would potentially see multinucleated red blood cell precursors. So we could see erythroblasts with more than one nucleus, and abnormal for normal erythropoiesis. That is not a typical finding. We may also see abnormal nuclear shapes. That includes nuclear lobes, nuclear buds, fragments, and nuclear bridging. We may also see ringed sideroblast, which, as mentioned before, are those erythroblasts with iron-loaded mitochondria encircling the nucleus. It's also seen with that Prussian blue stain. We may also see megaloblastoid cellular development, which resembles megaloblastic anemia, like vitamin B12 or folate deficiency. And this is due to asynchronous nuclear cytoplasmic maturation, but not responsive to the vitamin replacement. Dysmyeloid poiesis refers to abnormal granulocyte, especially on the myeloid cell, development, which is evident in the peripheral blood smear. So some features in that blood smear for dysmyelopoiesis is we would see nuclear cytoplasmic asynchrony, which is a mismatch between nuclear and cytoplasmic maturation. Cytoplasm can appear mature while the nucleus will remain immature, or even vice versa. We may see basophilia in the cytoplasm of mature white blood cells. So we'll have a persistent blue tint in the cytoplasm of otherwise mature-looking granulocytes. We may have abnormal granulation of neutrophils. This can include hypogranulation or agranulation. Hyposegmentation may also be seen, and this is where there's fewer than normal nuclear lobes in the neutrophils. We may also see something called pseudo-Pelger-Hewitt anomaly, and this is where they have bilobed or unsegmented neutrophils present. We may also see the opposite of that, where we have hypersegmentation, so neutrophils with more than 5 nuclear lobes, and this is typically associated with vitamin B12 and folate deficiency, but can also be seen in dysmyelopoiesis. Nuclear rings we may see as well. These are abnormal nuclear morphology where the chromatin forms ring-like structures within the granulocytes. For the bone marrow, dysmyelopoiesis will show as abnormal maturation in morphology of the myeloid precursors. Some lab findings in the bone marrow, we would see nuclear cytoplasmic asynchrony again. We'll have that mismatch between nuclear and cytoplasmic development. So an example would be like a mature cytoplasm with immature nucleus, or again, vice versa, just like on the blood smear. We could have uneven cytoplasmic staining, so irregular distribution of cytoplasmic basophilia, and that can just suggest dysfunctional maturation. May also have abnormal granulation, which may include hypogranulation or agranulation. We may also see abnormal coarse granules as well. And we can also see these in the myelocytes and promyelocytes. Might also see Auer rods, which are abnormal needle-like inclusions in the cytoplasm. These are typically associated with acute myeloid leukemia, but can be seen in this as well. And it suggests high-risk disease or impending transformation to leukemia. We also may see hypersegmentation of nucleoli. So nucleoli with more than 5 lobes is usually abnormal for a granulocyte precursor. On the flip side, we may see hyposegmentation, and that is fewer than normal nuclear lobes. Again, pseudo-Pelger-Hewitt cells, just like we saw in the blood smear. Ring-shaped nucleoli, we have abnormal nuclear looping or full ring formations, and it could be a sign of significant dysplasia in the granulocytic lineage. Dysmegakaryopoiesis refers to abnormal development and morphology of megakaryocytes and their platelet progeny. For peripheral blood findings, we're going to see giant platelets. These are abnormally large platelets, and they are often functionally abnormal. We're also going to see abnormal platelet granulation, so we may see hypogranulation and even agranulation within these platelets, and it can lead to a defective platelet function. As far as bone marrow findings, we're going to see large mononuclear megakaryocytes, so these are megakaryocytes with a single round nucleoli instead of it being multi-lobed. We may also see micro megakaryocytes, so these are small abnormal megakaryocytes, and they may look like like lymphocytes or even blasts. Then we have micromegakaryoblast. These are immature and very small megakaryocytic precursors. And these are often difficult to distinguish from other small blasts because they all kind of look the same. So then we have bilobed nuclei. So this is with they have nucleoli that have 2 distinct lobes, or they look like a dumbbell shaped. This is characteristic of a dysplastic feature. We have multiple small or separated nucleoli. So instead of a single lobulated nucleus, megakaryocytes may have several separate nucleoli, and they'll have a disorganized nuclear division as well. So to determine the cause of dysplasia, so before diagnosing myelodysplastic syndrome, it's essential to exclude other conditions that can mimic dysplastic features. So we need to rule out myelodysplastic syndrome, ones that they can actually mimic. So vitamin B12 or folate deficiency. This can cause megaloblastoid changes, hypersegmented neutrophils. So because it kind of will resemble it, we need to check serum levels before we try to confirm any myelodysplastic syndromes. Same with copper deficiency. It can lead to cytopenias and dysplasia, especially neutropenia. So this may be seen in malabsorption or even post-bariatric surgery. Fanconi anemia is another one that will be very similar. This is an inherited bone marrow failure syndrome. And this presents with cytopenias, dysplastic marrow, especially in younger patients. Another one is parvovirus B19 infection. This actually targets erythroid precursors, causes as a red cell aplasia, and it may mimic dyserythropoiesis. Another thing it may mimic or look like is drugs and chemicals. So certain agents may induce dysplastic changes. So we have chemotherapy, anti-epileptics, alcohol, and toxins such as benzene. For clinical evaluation, you're going to look for a detailed patient history. You're going to look for if the patient has had prior chemotherapy or radiation, if they've had any occupation or environmental exposures, and you want to get a list of their medication history as well. For their physical examination, you're going to look for clues to inherited syndromes, if there's any nutritional deficiencies or any infections. In addition to morphological abnormalities, mature blood cells in myelodysplastic syndromes often show impaired function, which contributes to clinical symptoms. So granulocytes or neutrophils will have a decreased adhesion, so they'll have an impaired ability to adhere to endothelium, which affects immune response and migration to infection sites. They'll have deficient phagocytosis as well, which is reduced capacity to engulf and destroy pathogens, which increases susceptibility to bacterial infections. We might have decreased chemotaxis, which is poor directional movement toward the chemical signals, which further limits microbial killing capacity. For the erythrocytes, they may have shortened survival, so red blood cells are often destroyed prematurely, which can contribute to the anemia. We may also have decreased response to erythropoietin, so the bone marrow fails to respond adequately to erythropoietin stimulation, which will result in chronic anemia, which is often going to be transfusion dependent. Then we move on to platelets. So they may have an increased bleeding despite normal or near normal platelet count. So platelets may be numerically adequate, but they are functionally abnormal. And this can lead to easy bruising, prolonged bleeding, and mucosal hemorrhages. For the classification of myelodysplastic syndromes, we have the French, American, British, or the FAB classification. So the FAB classification was one of the earliest systems that was developed to categorize myelodysplastic syndromes, and that's based on morphological features. Key features of the FAB classification divides myelodysplastic syndrome into 5 major subtypes, and this is based on the degree of dysplasia and the percentage of blast in the bone marrow. It relies on morphology alone, and it lacks cytogenetic or molecular data, so it has limited prognostic value in modern practice. Then we have the WHO classification. It provides a more detailed and clinically relevant categorization of myelodysplastic syndrome, and this incorporates morphology, cytogenetics, and blast count. These are a group of clonal hematopoietic disorders with overlapping features of the myelodysplastic syndromes and myeloproliferative neoplasms. So chronic myelomonocytic leukemia, this is characterized by persistent monocytosis, features both dysplasia and proliferation, blasts are less than 20%, and can present with splenomegaly and systemic symptoms. Atypical chronic myeloid leukemia, with the BCR/ABL1 negative, resembles chronic myelogenous leukemia clinically, but lacks that BCR-ABL1 fusion gene. You'll see marked leukocytosis with dysplastic granulocytes, we'll see prominent neutrophilic proliferation with dysplasia. Juvenile myelomonocytic leukemia will occur in children, features monocytosis, dysplasia, and myeloproliferation, and is often associated with mutations in the RAS pathway genes. Now we have MDS-MPN with ring sideroblast and thrombocytosis. This combines features of the myelodysplastic syndrome with ring sideroblast and a marked thrombocytosis. It will often show the SF3B1 mutation and the JAK2 V617F mutation as well. For the myelodysplastic, myeloproliferative, neoplasm unclassifiable. These are just cases that don't fit the criteria for any of the above categories, and it shows overlapping dysplastic and proliferative features without a defined subtype. Now, you don't need to memorize these by any means, but it would be good to know. All right, so cytogenetics and molecular alterations in myelodysplastic syndrome. So incidence of chromosomal abnormalities. So we have the de novo myelodysplastic syndrome. Approximately 50% of patients have detectable chromosome abnormalities. There's also therapy-related myelodysplastic syndrome. This has a much higher incidence where there is 90 to 95% with abnormalities. There's a clinical significance of the karyotype. So prognostic importance is there certain abnormalities can predict better or worse outcomes. We can also predict response to treatment, so it will help guide therapy decisions. For molecular alterations, the frequency is about 90% of MDS patients harbor at least one somatic mutation. Median number of mutations per patient is 3. Commonly mutated genes are those that are listed there. I'm going to just pick out a couple of them. So we have the TET2, and that's involved in DNA demethylation. Then we have the DNMT3A, which is a DNA methyltransferase, and that's involved in epigenetic regulation. For treatment of myelodysplastic patients, it's pretty challenging because many are older and already probably have coexisting illnesses, and the heterogeneity of the disease makes the use of one standard treatment basically impossible. So our treatment goals for this is really just to improve quality of life, prolong survival, manage the symptoms that are related to cytopenias, and disease progression. For supportive care measures, we have transfusion. So we can do red blood cell transfusions for anemia, platelet transfusions for bleeding, or thrombocytopenia. Can also give erythroid stimulating agents, which will stimulate red blood cell production, and that's useful in patients with low transfusion needs and low erythropoietin levels. For thrombopoietin receptor agonists, we can promote platelet production, and that's used in the thrombocytopenic patients. Granulocyte colony stimulating factor will stimulate neutrophil production and may reduce infection risk in neutropenic patients. Prophylactic antibiotics can also be used, and this is used in patients with recurrent infections or severe neutropenia. Iron chelation therapy that prevents iron overload from repeated transfusions, and this is important for long-term management. For immunosuppressive therapy, it's considered in selective patients, especially with hypoplastic myelodysplastic syndrome or evidence of immune-mediated marrow failure. We can also do the lenalidomide, which is particularly effective in the myelodysplastic syndromes with isolated DEL or the 5q gene. It improves anemia and reduces transfusion dependence. And then we can also use the hypomethylating agent, and that is used in low to intermediate risk myelodysplastic syndrome with significant cytopenias or excess blasts. It works by reversing abnormal DNA methylation, restoring normal gene expression. It can delay progression to acute myeloid leukemia and improve survival. Last but not least is we have stem cell transplantation. This is the only curative therapy for myelodysplastic syndrome. This is considered in younger patients, those with higher risk disease, and it's also suitable for people who have, if they have a donor availability or anything like that. It involves allogenic hematopoietic stem cell transplantation, but there are risks, of course, and it includes graft versus host disease and treatment-related mortality.